In the end, there was no significant clinical MRI outcomes between the two groups. However, this was a very small study. One patient was lost to follow-up, and of concern, one patient in the immediate treatment group had 16 new lesions on MRI. About a third of patients were found to have restenosis, as measured by the imaging tools mentioned before. I'd like to move now on to complications that have been reported in the literature. So, angioplasty complications from the initial trial, minor bleeding was reported, postoperative headache in 6 subjects. At ECTRIMS, a poster was presented by Simca, where complications related to difficulty in removing the delivery system or the balloon, transient cardiac arrhythmia, minor bleeding, and unsuccessful catheterization. One of the major difficulties with this data was that there was no explanation as to how the complications were monitored and for how long patients were supervised. There are 2 other complications reported in the literature, one fatal blood clot in the brain, and open heart surgery after a jugular vein stent dislodged into the right ventricle. There have also been other complications that are not yet reported in the literature, reported either by the media, complications I've experienced with my own patients, and complications that have been shared with me by the clinicians with whom I work with. And I would like to touch on those briefly. There's been a second death from internal bleeding. There's been quite a few reports of clots in the stents. There's been reports of chest pain, pulmonary embolism, which is a clot that migrates to the lungs, and I explained in the beginning of my presentation the anatomy of that. Serious neck pain, a stent that migrated into the kidneys, and a possible brainstem stroke or nerve injury. My advice would be to those patients who seek alternate treatment at this time that if you experience sudden chest pain, shortness of breath, evidence of bleeding or bruising, that you should seek urgent medical attention. And from a physician's perspective, we do have an ethical and moral obligation to treat any patient with a complication, irrespective of how that complication came about. The difficult part, and the part that I think is important to recognize, is that sometimes the best treatment for a complication may be no treatment, because sometimes intervention could lead to further harm. And this, I think, needs to be recognized. And so I've often heard from my patients that thousands of people have gone abroad and report improvement in their MS symptoms. Is this not evidence that the procedure works? And this observation, this experience that patients have is incredibly important and should not be ignored. It is from your observations that we learn and that we ask questions and that we improve the standard of care. But unfortunately, the experience of the patient alone without science is not enough to improve the standard of care. We require as well an evidence-based process by which to evaluate possible new treatments. The limitations of the anecdotal experience or the patient experience alone can be summarized by some of these factors here. For example, other treatments that occur at the same time as the administration of the new treatment that are not controlled for could have an effect on the outcome. Many patients have decided to take up an exercise program or a physiotherapy program in combination with pursuing another alternative treatment, be it balloon angioplasty. The other issue is that there is an expectation effect. If you believe that you're going to improve, there is a certain amount of expectation, and that expectation itself may have an impact on your function and your quality of life. We do know that the expectation effect itself can have neurochemical changes in the brain, and this was recently summarized in a Lancet 2010 article. We do not really understand the effect of these neurochemical changes and how they may influence performance, function, and quality of life. But they are not the direct effect of the treatment intervention itself. And this is why it is so important to have a control group when you're studying a new treatment, because you want to know whether it's the expectation effect that's caused the change or whether it's the treatment itself. The other problem is that the patient experience is sometimes limited in follow-up. And if we have properly designed research trials, we hope that we'll be able to follow patients up for a long time and know the long-term outcomes, which is especially important in a disease that is lifelong. And finally, the variability of the disease course in MS makes it particularly difficult to study, because even with no treatment, any one day in the office, I have patients who are worse, who are the same, or who are better. I would like to just briefly review angioplasty in medical practice. It is not the standard of care in the treatment of disorders of the vein, but rather it is the standard of care for coronary artery disease, and these are arteries, and carotid neck arteries and stroke. Similarly, stents in the jugular veins are not the standard practice and are the standard practice in coronary artery disease or in stroke or in occluded arterial venous fistulas and diabetics. Jugular venous stents are not inserted in routine clinical practice. This is experimental practice. Catheters may be placed in the jugular vein in certain critical medical circumstances, diabetics on dialysis. And these patient populations have terrible outcomes, particularly in comparison to MS, with respect to mortality rates. Finally, getting towards the end here, Vina stenosis, it is becoming more and more apparent, occurs not only in MS, but also in normals and perhaps in other conditions as well. And I dug up this paper from 2004, which showed in 42% of diabetic patients undergoing dialysis, an incidental finding of stenosis or narrowing in the internal jugular veins. And interestingly, this abnormality or narrowing was twice as common if the diabetic patient had had a previous insertion of a temporary catheter, suggesting that tampering with these veins may increase the risk of subsequent stenosis down the line. In this patient series, no subject was reported to have MS. So in conclusion, I'm very optimistic in that we have come a long way in our imaging capabilities, and this has allowed us to better understand MS. This is a picture from Fogg in 1963, who described the association between venous vessels and plaques in some, but not all, of the MS lesions. And here we have MRI and the synchrotron technology showing the distribution of iron. In conclusion, endovascular intervention is not recommended by healthcare professionals or the scientific community at this time unless controlled trials demonstrate benefit, that venous anatomy and physiology is indeed highly variable between individuals, and that certainly the role of blood flow in general, as well as the role of iron in MS, warrants further study. And this is our research team. We have quite a large research multidisciplinary team looking at this issue in particular. Thank you.